Good morning, everyone. This is Dr. Amanda Cohn, and welcome to the second full virtual ACIP meeting, although there have been several emergency meetings in between. Next slide. All of our meeting materials are available on the ACIP website. This meeting is being live webcast. Meeting participants are participating in a Zoom call. For those of you who wish to see the slides while the meeting is going, you can open the slides. The slides are available on the ACIP website today. However, they are not 508 compliant, so they will be taken down at the end of the meeting, made 508 compliant, and then put back up in about a week or two. Next slide. So slides will be posted approximately 4 weeks after this meeting. The live webcast videos will also be posted on the ACIP website approximately 4 weeks after the meeting. And meeting minutes are posted on the ACIP website generally within 120 days of the meeting. Next slide. For those of you who are participating on the Zoom call, please mute your lines at all times unless you're called on for discussion. When Dr. Romero opens the meeting for discussion, please virtually raise your hand. And during the discussion period, Dr. Romero will take questions first from voting ACIP members and then from ex officio members and liaison members. We will stay on schedule as much as possible per the meeting agenda. So even if we're running early, we will come back at the scheduled time. This may adjust. This is a 3-day meeting, and we want to use people's times valuably, but we also want to make sure that people do know when the sessions are beginning. We're asking that all ACIP members please disable your video for better audio conferencing. Next slide. These dates show the next full ACIP scheduled dates. The meeting in February 24th through 25th will be a virtual meeting. We are not saying the meeting June 23rd and 4th is virtual yet. That decision will be made in the spring, and we'll see where we're at. And if we're able to have an in-person meeting, we will be hopeful that that can happen. And then our third meeting is October 20th to 21st in 2021. These meeting dates do not include emergency ACIP meetings we anticipate as COVID-19 vaccines are brought to FDA for consideration for emergency use authorization. As described during prior meetings, we will have an ACIP meeting to deliberate recommendations for use for any COVID-19 vaccine product immediately after an EUA has been authorized. So stay tuned and look for announcements on our ACIP website about additional ACIP meeting dates. And if you'd like to receive email announcements, you can sign up at the bottom of the ACIP page for updates. Next slide. We will have a public comment period today during this meeting. Our oral and written public comment processes are designed to ensure that the public has an opportunity to inform ACIP's considerations for immunization recommendations. We are trying to maximize opportunities for comment and make the public comment process more transparent and efficient. We have a lottery system for times when too many individuals have signed up for public comment, where we assign the limited oral public comment time. But we encourage the public to submit comments via the the regulations.gov docket, and the docket number is on the ACIP website. Those comments are reviewed by ACIP members and available for all of the public to review as well. Next slide. Members of the ACIP agreed to forego participation in certain activities related to vaccines during the tenure on their committee. CDC has issued limited conflict of interest waivers as follows for members who either conduct vaccine clinical trials or serve on data safety monitoring boards. Those individuals are prohibited from participating in committee votes related to those particular vaccines although they may continue to be ACIP members and deliberate and vote on vaccines which the companies that they're participating in trials on are not putting forward. At the beginning of each ACIP meeting and prior to each vote, ACIP members will state any conflicts of interest. Next slide. I'm going to turn it over to our venerable chair, Dr. Romero, to begin to take roll call. I do want to say one thing before we get started with today's meeting. This is going to be a very long 3 days. We have meeting times scheduled starting at 10 a.m. and going through the afternoon with a lot of topics and varied vaccine products that are going to be talked about. So we appreciate everyone's time and effort to make this happen, to be here with us virtually for what will be one of the longer meetings we've had for ACIP. We also want to encourage people to use their breaks and stand up and not be sitting in front of their computers for all of these hours. Once again, we know this both from the members, the ex officios and liaisons, and the public who really stays tuned to this entire meeting. We appreciate how extensive this will be and hard this will be to do virtually today. But at least maybe you'll have good lunch options. So I will pass it over to Dr. Romero at this time to start roll call.
So let me add my welcome to everyone. I'll begin with roll call with the ACIP members, then followed by the ex officio representatives and then liaison representatives. For the ACIP members, when I call your name, please indicate whether you're present, your affiliation, and whether you have any conflicts of interest. So I will begin. Jose Romero, present. I am Secretary of Health for the state of Arkansas, Professor of Pediatrics and Pediatric Infectious Diseases at the University of Arkansas for Medical Sciences, and I have no conflicts. Dr. Atmar.
President Robert Atmar, Professor, Section of Infectious Disease, Department of Medicine, Baylor College of Medicine. For a potential conflict, I'm a co-director of the Clinical Operations Unit of the NIH-funded Infectious Diseases Clinical Research Consortium that is working within the COVID-19 Prevention Network to evaluate SARS-CoV-2 vaccine candidates in phase 3 clinical trials, including those produced by Moderna, AstraZeneca, Janssen, Novavax, and Sanofi. Over.
Thank you. Dr. Alt.
Ken Alt, present. I'm a professor and division director at the University of Kansas Medical Center in Kansas City, Kansas, and I have no conflicts.
Thank you. Ms. Bata.
Good morning, I'm present. I am Lynn Bata. I am a public health nurse and function as the immunization clinical consultant for the Minnesota Department of Health.
Did you mention your conflicts, Dr. Ms. Bata?
I have no conflicts.
Thank you. Welcome. Dr. Bell.
Beth Bell, I'm present. I'm a clinical professor at the University of Washington in Seattle, Washington, and I have no conflicts.
Welcome, thank you. Dr. Bernstein.
Good morning. I am present. I am a professor of pediatrics at the Zucker School of Medicine at Hofstra Northwell, and I have no conflicts.
Thank you. Welcome. Dr. Fry.
Good morning. This is Sharon Fry. I'm a professor of internal medicine at St. Louis University, and I'm also the clinical director of the university's Center for Vaccine Development. Currently, I am conducting SARS-CoV-2 trials, phase 3 trials.
Thank you and welcome. Dr. Hunter.
Paul Hunter, Associate Professor of Family Medicine and Community Health at the University of Wisconsin in Madison, and also a medical consultant on communicable diseases for the City of Milwaukee Health Department. I own a small amount of Pfizer stock and have received a small grant from Pfizer to do quality improvement project on shared decision-making for pneumococcal vaccines. Thanks.
Thank you and welcome. Dr. Lee.
Grace Lee, Associate Chief Medical Officer at Stanford Children's Health, Professor of Pediatrics at Stanford University School of Medicine, and I have no conflicts.
Thank you and welcome. Ms. McNally.
Good morning, Veronica McNally, present. I am the president of the Franny Strong Foundation, a nonprofit organization located in Michigan, and I have no conflicts.
Thank you and welcome. Dr. Paling.
Good morning. This is Kathy Paling. I am a professor of pediatrics and epidemiology at Wake Forest School of Medicine. I also serve as the director of pediatric population health. I have no conflicts.
Thank you and welcome. Dr. Sanchez.
I'm Pablo Sanchez. I'm a neonatologist and pediatric infectious disease at Nationwide Children's, the Ohio State University in Columbus. I have no conflicts.
Thank you. Welcome. Dr. Szilagyi.
Good morning, Peter Szilagyi, present. I'm a professor and executive vice chair of pediatrics at UCLA, and I have no conflicts.
Thank you and welcome. And Dr. Talbot.
Morning, I'm Kip Talbot. I'm an associate professor in the Division of Infectious Diseases at Vanderbilt University Medical Center, and I have no conflicts.
Thank you and welcome. Now I will call the ex officio representatives, and I will call you by your institution, and then please state your name at that time. So Centers for Disease Control, Nancy?
Hi, this is Nancy Messonnier, Centers for Disease Control, National Center for Immunization and Respiratory Diseases. Good morning, everybody.
Good morning. Food and Drug Administration.
Good morning, Doran Fink from FDA Center for Biologics Evaluation and Research, Office of Vaccines.
Good morning, thank you. The Health Resources and Services Administration, please.
Good morning, this is Mary Rubin. I'm with the Division of Injury Compensation Programs, HRSA.
Thank you, good morning. Indian Health Services.
Good morning, Tom Weiser with the Portland Area Indian Health Service.
Good morning, welcome. National Institutes of Health.
Good morning, John Bargo from the Division of Microbiology and Infectious Disease, NIAID, NIH.
Welcome and good morning. Office of Infectious Diseases and HIV/AIDS Policy.
David Kimball, YDP.
Thank you. Welcome. All right, we'll turn now to the liaison representatives. Again, I will list, I will call out the parent organization. Please state your name as you answer. Present. American Academy of Family Physicians.
Pamela Rockwell, present.
Thank you. Welcome. American Academy of Pediatrics.
David Kimberlin, AAP Red Book, present.
Good morning. Welcome. American Academy of Physician Assistants.
Good morning, Marie-Michelle Léger, present.
Good morning. American College of Health Association.
This is Tavi Chai, present.
Good morning. American College of Nurse Midwives.
Carol Hayes, present.
Thank you. Good morning. American College of Obstetricians and Gynecologists. American College of Obstetricians and Gynecologists. We'll come back to that. Thank you. American College of Physicians.
Jason Goldman, present.
Good morning. American Geriatric Society.
Ken Schrader, present.
Thank you. Good morning. American Immunization Registry Association.
Good morning. Rebecca Coyle, present.
Thank you. Good morning. American Immunization Registry Association. Oops, sorry, did I skip somebody? Sorry. American Health Insurance Plans. American Health Insurance Plans?
Bob Gluckman, present.
Thank you. American Medical Association?
Sandra Freihofer, general internist in Atlanta and adjunct associate professor of medicine at Emory, representing the American Medical Association.
Thank you and good morning. American Nurses Association?
Chad Riddle, American Nurses Association.
Thank you. Good morning. American Osteopathic Association?
Dan Growlett, and present, and good morning.
Morning. American Pharmacists Association?
Good morning, this is Steve Foster.
Thank you. American Immunization Registry Association? American.
Maybe the Association of Immunization Managers, and Chris Finley is present.
Thank you. American Pharmacists Association?
Steve Foster, I'm here.
Thank you. Good morning. Association of Immunization Managers? Oh, you've answered already. Sorry, Dr. Finley. It's on the flip side. American Health Insurance Plans?
Yeah, this is Bob Gluckman. I called on me already.
Yeah, sorry about that. You're listed on both sides here. Association of State and Territorial Health Officials? Association of State and Territorial Health Officials? We'll come back. Thank you.
Susan Lett, present.
Thank you. And welcome. Council of State and Territorial Epidemiologists?
Christine Hahn, present.
Say again, please.
Christine Hahn, present.
Thank you. Canadian National Advisory Committee on Immunization?
Carolyn Kwasniewski, chair, present.
Good morning, thank you. Infectious Diseases Society of America?
Carol Baker, present.
Thank you, good morning. International Society for Travel Medicine? Okay. International Society for Travel Medicine? Okay, we'll come back. National Association of County and City Health Officials?
Morning, Matt Zahn, present.
Good morning, thank you. National Association of Pediatric Nurse Practitioners?
Good morning, Patsy Stinchfield's present.
Thank you. National Foundation for Infectious Diseases?
William Schaffner, present. Good morning.
Morning. National Medical Association?
Patricia Whitley Williams, present. Morning.
Thank you, good morning. Pediatric Infectious Diseases Society?
Good morning, Sean O'Leary, present.
Morning. Pharmaceutical Research and Manufacturers of America?
Good morning, Corey Robertson, present.
Thank you, good morning. Society for Adolescent Adolescent Health and Medicine?
Hi, good morning, everyone. It's Amy Middleman. I'm present. Thanks.
Good morning. Society for Health Epidemiology of America?
Good morning, Marcy Dries, present.
So let me see, we'll try again with International Society for Travel Medicine. Okay. Association of State and Territorial Health Officers. Thank you all very much. Welcome to the meeting, and thank you for giving of your time. So we'll move on now to our first topic, which is the immunization schedules. Excuse me. This will be an introduction by Dr. Bernstein and Dr. Alt, introduction to the combined immunization schedule work group. Dr. Bernstein, Dr. Alt, please.
Good morning again.
So today we plan to share the combined work group's recommendations for the 2021 immunization schedules for children and adolescents and adults. I'd like to first recognize my co-chair, Dr. Alt, and of course our CDC co-leads, Drs. Friedman and Wody. These three are incredibly meticulous and detailed in making this all come together so smoothly. Next slide, please. Am I supposed to advance? Oh, there we go. As many of you know, the goal of the combined schedule work group is to better harmonize the child and adolescent and adult schedules. Next slide, please. The combined work group had 5 ACIP members this year, including myself and Kevin Alt as co-chairs, along with the wonderful input from Paul Hunter, Veronica McNally, and Peter Szilagyi. I also would like to recognize the many contributions of our liaison representatives listed on the left side of the slide, as well as those of the ex officios, consultants, and again, the CDC co-leads listed on your right. Next slide, please. We also want to acknowledge the expertise and valuable involvement of the talented CDC contributors listed here. Next slide, please. This slide is intended to remind the committee and the audience why we present the schedules for vote every fall. The ACIP's approval is necessary prior to publication of the immunization schedules in February of the following year. ACIP approval is also necessary before we have our partners, the American College of Physicians, the American Academy of Pediatrics, the American Academy of PAs, the American Academy of Family Physicians, the American College of Obstetricians and Gynecologists, the American College of Nurse Midwives, and the Pediatric Nurse Practitioner Association. Review and approve the schedules. Also, you'll recall that no new policy is established by these adult and pediatric schedules. Rather, they reflect a summary of published ACIP recommendations. Next slide, please. For the remainder of this presentation, Dr. Wody will discuss the proposed edits for the 2021 child and adolescent schedule, and Dr. Friedman will discuss the proposed edits for the 2021 adult immunization schedule. These edits are intended to incorporate ACIP recommendations and MMWR publications that have occurred since October 2019. Improve readability and utility of the schedules into language that is easy to interpret at point of care for the busy provider. In addition to harmonization, there are proposed edits to tables 1 and 2. There also are content changes for the notes section of both schedules that will be shared. This session will conclude with a discussion of the proposed edits, followed by a vote on the adult and the child and adolescent schedules later today. Next slide, please. Lastly, please note that the use of trade names is for identification purposes only and does not imply endorsement by the CDC. I will now ask Dr. Wody to lead us through the proposed edits in the child and adolescent schedule. Thank you.
Thank you, Dr. Bernstein. Good morning. Can everyone hear me? Yeah. I will present the proposed edits for the 2021 child and adolescent immunization schedule. Next slide, please. This is a list of ACIP votes relevant to the child and adolescent immunization schedule that have occurred since October 2019. The 2021 schedule has been updated to reflect published recommendations regarding influenza vaccination and also to include menquafi as an option for preventing disease attributed to meningococcal serogroups A, C, W, and Y. Next slide, please. First, I'll present edits made to the cover page. Next slide, please. The table of abbreviations and trade names has been updated to include Menquafi to the list of meningococcal ACWY vaccines. Also, Vaxelis has been added to the list of combination vaccines. Next slide, please. The abbreviation for live attenuated influenza vaccine was changed from LAIV to LAIV4 because only the quadrivalent formulation is currently available in the United States. Next slide, please. Table 1 is the graphical presentation of the routine immunization schedule. Next slide, please. Minor edits have been proposed for Table 1. In the hepatitis B row, we have added arrows to the second dose to clarify the recommended age range for administering the second dose. As noted earlier, the abbreviation for live attenuated influenza vaccine has been updated to specify the quadrivalent formulation. Next slide, please. Table 2 is the catch-up immunization schedule for children and adolescents. Next slide. No edits have been proposed for Table 2. Next slide. Next, I would highlight the changes to Table 3, which is the graphical presentation of recommended immunization based on medical indication. Next slide. In the HPV vaccine row, the color for the pregnancy column has been changed from pink, which indicated delaying vaccination until after pregnancy, to red, which indicates not recommended or contraindicated. Vaccine should not be administered. In addition, an overlying text that reads not recommended with an asterisk has also been included in that column. The asterisk links to a descriptive text in the red box within the legend, indicating HPV vaccine can be given after pregnancy. Next slide. Similar to the HPV row, the pregnancy column from MMR and varicella vaccines have been updated to include the overlying text, not recommended, with an asterisk that links to the descriptive text in the red box in the legend, clarifying the vaccine, if indicated, may be administered after pregnancy. Next slide. Similar to the cover page and Table 1, we have updated the abbreviation in the row for live attenuated influenza vaccine and the footnote to reflect the quadrivalent formulation. Next slide. Finally, I would review the edits to the notes section of the schedule. Next slide. Under the additional information, the sentence on when to administer a repeat dose after a dose was administered before the recommended minimum age or interval has been made bold so that it's clear to the people who use the schedule. Next slide. Within the DTAP note, a section on special situation has been added with recommendations for the use of DTAP for wound management in children less than 7 years. It reads, in children less than age 7 years with 3 or more doses of tetanus toxoid containing vaccine, for all wounds besides clean and minor wounds, administer DTAP if more than 5 years since last dose of tetanus toxoid containing vaccine. A web link to the relevant MMWR publication has also been included. Next slide. A minor edit was made to the HIP note for catch-up vaccination, and this was to include a new bullet clarifying no further doses are needed for children who receive 1 dose of vaccine at age 15 months or older. Next slide. The notes for hepatitis A vaccination was a minor change was made to the notes on hepatitis A vaccination regarding the 4-dose series for combined Hep A, Hep B vaccine. This was to clarify the 4th dose at 12 months is a booster dose. Next slide. In the notes for hepatitis B vaccination, the sentence pertaining to infants born at less than 2,000 grams has been updated with additional language. The sentence now reads, administer 1 dose at chronological age 1 month or hospital discharge, whichever is earlier, and even if weight is still less than 2,000 grams. This edit was made to provide further clarification regarding when the vaccine can be administered to infants with birth weight less than 2,000 grams. Next slide, please. The notes on routine and catch-up vaccination for HPV vaccine was updated to include a new bullet with information on the recommendation for interrupted schedules. If the vaccination schedule is interrupted, the series does not need to be restarted. Next slide, please. The influenza note was updated to specify the quadrivalent formulations for live attenuated influenza vaccine and recombinant influenza vaccine. In the section on special situations, the language for persons who have egg allergy with symptoms other than hives was revised to reflect ACIP's recommendations for the 2020-21 influenza season. The bullet now reads, if using an influenza vaccine other than Flublok or Flucelvax, administer in medical setting under supervision of healthcare provider who can recognize and manage allergic reactions. New bullets with information on severe allergic reactions after influenza vaccination were also added to emphasize that a previous severe allergic reaction to influenza vaccine is a contraindication to future receipt of the vaccine, and that vaccine providers should be familiar with the office emergency plan and be certified in cardiopulmonary resuscitation. Regarding situations where early IV4 should not be used, a new bullet, children less than 2 years, was added. Also, the bullet on receipt of influenza antiviral medication was revised to reflect ACIP's recommendation for the 2020-21 influenza season. Next slide. Within the notes of meningococcal serogroup ACWY, Menquafi was added to the list of vaccine in the sections on routine vaccination, catch-up vaccination, and special situations. The special situations section was also updated with language on the recommendations for the use of MenACWY CRN, trade name Menvio, in infants who received dose 1 at age 3 through 6 months and have certain medical conditions or indications, including anatomic or functional asplenia, HIV infection, persistent complement component deficiency, use of complement inhibitors, or travel in countries with hyperendemic or epidemic meningococcal disease. These updates were made to reflect ACIP's current recommendations on meningococcal vaccination. Next slide, please. Minor edits were made to the notes on pneumococcal vaccination. High-risk condition was changed to underlying condition, and language was added to clarify PPSV 23 should be administered after all recommended PCV 13 doses have been completed. Next slide, please. Similar to the DTAP note, a special situation section has been added to provide information on the use of Tdap for wound management in persons aged 7 years or older. It reads, in persons aged 7 years or older with 3 or more doses of tetanus toxoid containing vaccine. For clean and minor wounds, administer Tdap or Td if more than 10 years since last dose of tetanus toxoid containing vaccine. For all other wounds, administer Tdap or Td if more than 5 years since last dose of tetanus toxoid containing vaccine. Tdap is preferred for persons aged 11 years or older who have not previously received Tdap or whose Tdap history is unknown. If a tetanus toxoid containing vaccine is indicated for a pregnant adolescent, use Tdap. The web link has also been updated to the more recent publication. Next slide, please. Thank you, and I'll take any questions at this time.
Thank you, Dr. Woody. Any questions at this time from the members? Dr. Szilagyi, are you trying to raise your hand? We're having some trouble seeing your hand up.
No, I'm not.
Okay, thank you very much.
This is Dr. Atmar. I'm trying to, but I'm having trouble.
Okay, Dr. Atmar, go ahead.
I have a question about the, let's see, it's slide 18 and 19. And the question I have relates to some of the red cells contain no language, and some had the not recommended information put into the cell. And I was wondering why some contain not recommended and others don't, when the footnote basically says it's not recommended / contraindicated.
Yeah, for the pregnancy column, we wanted to indicate that for some of those vaccines, they could be used after pregnancy. So that's why we added the overlying text in those columns. And I guess an option is just to put the asterisks and leave the not recommended, but we thought that it would be clearer if we added not recommended with the asterisk.
I actually find it confusing that some contain not recommended and most of them don't, since that's what I interpret the red color to indicate. Over.
So do we see that as a fix going forward, Dr. Woody?
Yes, we can remove all the other thing I'll mention is that we were trying to harmonize the adult and the child and adolescent schedule, and the adult schedule has not recommended in some of the boxes too.
Very good, thank you. Any other questions or comments from the voting members? All right, let me turn it over to Dr. Hayes.
Sorry, I was having difficulty unmuting, yes. So I don't have a copy of the slides, and so I can't tell you which slide it is, but it was near the end on the notes section. And there was, keep going down, it has to do with pregnancy on the top right, whatever page that is. Keep going down. I think it's closer to the very end. So wherever it's okay, here we go. So my suggestion is that you have a third bullet under routine vaccination when that third bullet really is a continuation of the subject of pregnancy. So I would recommend that you have a period at the end of the first sentence, and that the third bullet become part of the second bullet, so that it says Tdap may be administered regardless of the interval. That's relating to pregnancy specifically. So I would just recommend that those are two separate sentences under one bullet.
Sorry, is that under routine vaccination?
Yes, on the top right where it says routine vaccination, the first bullet says adolescents, and the second bullet says pregnancy, 1 dose Tdap during each pregnancy, preferably early part of the gestational weeks. Then I would recommend that there be a period after 36, and that Tdap may be administered regardless of the interval should be a second sentence under the second bullet instead of being a third bullet, because I think it's really important that that recommendation about regardless of the interval, we have a real problem among nurse midwives in the country of feeling confident that it's safe to give it regardless of the interval. So I think that needs to be very clear that it's part of the routine vaccination during pregnancy.
Okay, thank you.
Certainly, thank you.
Dr. Bernstein, Dr. Alt, any comments on that?
This is Kevin Alt. I think that was our intention, so I agree with that change.
All right, very good. Any other questions or comments? Okay, I see none, so we'll move on to the next topic, which are the proposed changes to the 2021 adult immunization schedule by Dr. Mark Friedman. Dr. Friedman, please.
All right, thank you, Dr. Romero. I will be presenting the proposed updates for the 2021 adult immunization schedule. This is an overview of what I'll be covering over the next few slides. These represent ACIP votes relevant to the adult immunization schedule that have occurred since the October 2019 meeting, and also editorial changes to clarify notes or harmonize the adult schedule with the child and adolescent schedule. First, I'll highlight changes made to the cover page. There were some minor changes made. First, the abbreviations for LAIV and RIV have been updated that now reflect that those are both available as quadrivalent vaccines. So it's LAIV4 and RIV4. In addition, we added MEN-QUADFI to the list of MEN ACWY vaccines. And we also added the abbreviations for all 3 types of the meningococcal ACWY vaccines. We removed ZVL or zoster vaccine live from the table since it's no longer available on the market. And also from the injury claim section, there was a reference to ZVL that has been removed. And then under the helpful information section, we added a link to frequently asked questions regarding shared clinical decision-making. We receive a lot of questions about the shared clinical decision-making recommendation, and these FAQs were not available when the schedule was published last year, so we wanted to have them easily referenced for providers. Next, I'll highlight changes to Table 1, which is the recommended adult immunization schedule. In the influenza row, again, RIV and LAIV are now abbreviated RIV4 and LAIV4, again, reflecting the availability only of the quadrivalent vaccines of these vaccines. In the Tdap row, the row was split into 2, with the upper half colored purple to indicate vaccination is recommended for adults with an additional risk factor, for example, pregnancy and wound management. And the lower half is shaded yellow, indicating vaccination is recommended for adults. In addition, text overlay was added to the purple half of the row that states 1 dose Tdap each pregnancy, 1 dose TD or Tdap for wound management, and then a notation to see the notes for additional clarification. In the MMR row, the yellow color was extended through 50 to 64-year age column to reflect the age of persons born in 1957 or later. In the varicella row, the line between the yellow color and the purple color has been shifted to the left as well to reflect the age of persons born in 1980 or later. In the zoster row, we removed the row that referenced ZVL or Zostavax, since it's no longer available on the market. In addition, we removed the language that said that RZV was preferred, since that is now the only vaccine available for zoster. In the pneumococcal row, specifically PCV13, in the column for 65 years of age and older, the text overlay in the blue box was changed from greater than or equal to 65 years to 1 dose to be consistent with the other overlays in this table that reference doses and not ages. Next, I'll review edits to Table 2, which is the medical indications table. In the influenza row, again, we updated the abbreviation for RIV and LAIV to reflect the quadrivalent vaccines. In the MMR row, in the pregnancy column, an asterisk was added after not recommended, the not recommended text overlay, to indicate MMR vaccine should be administered after pregnancy. In addition, a line was added between the pregnancy column and the immunocompromised column to clearly separate them. In the varicella row, also in the pregnancy column, again, an asterisk was added to the text overlay not recommended to indicate that varicella vaccine should be administered after pregnancy. We also added a line between the pregnancy column and the immunocompromised column, again, to clearly separate them. In the column for HIV infection with CD4 counts greater than or equal to 200 cells per cubic millimeter, the color was changed to blue, indicating vaccination for this group is based on shared clinical decision-making. And this reflects the recommendation that vaccine may be considered for this group. And if it is considered, it would be 2 doses administered 3 months apart. In the zoster row, again, we removed any reference to ZVL or Zostavax since it's no longer on the market, and also removed the text that said that RZV was preferred. Sorry, got lost here. In the pregnancy column, also on the zoster row, the pink color for delay until after pregnancy has been replaced with the red color with the text overlay not recommended with an asterisk at the end. This was changed to simplify the schedule since the vaccine is not recommended during pregnancy, and instead it's recommended to give it after pregnancy. In the HPV row, again in the pregnancy column, we also removed the pink color for delay after pregnancy, and it's been replaced with the red color with the text overlay not recommended with an asterisk. Again, this was changed to simplify the schedule, and the vaccine is not recommended during pregnancy, and it is instead recommended to give after pregnancy. For the columns, asplenia and complement deficiencies through men who have sex with men, the text overlay has been modified to say 2 or 3 doses through age 26 years, depending on age at initial vaccination or condition. And the new language is depending on age at initial vaccination or condition. And that just more accurately reflects the recommendations. In the hepatitis B row, the text overlays in the columns asplenia through chronic liver disease now reads 2, 3, or 4 doses, depending on vaccine or condition. And this accounts for the accelerated twin-rick schedule, as well as dosing hepatitis B vaccine for persons undergoing dialysis. In the diabetes column, the cell has been split in two. The top half is yellow and indicates hepatitis B vaccine should be administered to persons with diabetes who are less than 60 years of age. The bottom half is now shaded blue, indicating that shared clinical decision-making should be used for vaccinating persons for hepatitis B who have diabetes and are 60 years of age and older. Lastly, I'll review changes made to the note section. Within the hepatitis A note, under travel in countries with high or intermediate endemic hepatitis A, we added text for the accelerated Twinrix schedule, which reads, Hep A, Hep B, Twinrix may be administered on an accelerated schedule of 3 doses at 0, 7, and 21 to 30 days, followed by a booster dose at 12 months. Within the hepatitis B note, under special situations, we added that hepatitis B vaccination for persons with diabetes who are age 60 years of age and older is now recommended by shared clinical decision-making. Within the within the human papillomavirus note, we had some minor wording changes. In the first bullet, HPV vaccination recommended for all persons through age 26, whereas last year it said it was recommended for adults through age 26. Under routine vaccination, we reformatted the first bullet about age 15 years of age and older at initial vaccination to match the language that's in the child and adolescent schedule. The previous wording was a little bit confusing and it was much clearer, so we changed it to that. Additionally, we added a bullet stating that no additional doses of HPV are recommended after completing a series using the recommended dosing intervals using any HPV vaccine that's on the market. In the shared clinical decision-making section, we modified the text slightly to say some adults aged 27 through 45 years instead of adults. And that was just to clarify and also to more accurately reflect the recommendations. Also, under special situations, we added 2 bullets. The first bullet states that age ranges recommended above for routine and catch-up vaccination or shared clinical decision-making also apply in special situations. And the second bullet states that immunocompromising conditions, including HIV infection, it is recommended to give a 3-dose series as above, regardless of age at initial vaccination. Under the influenza notes in the special situations section regarding egg allergy more severe than hives, we added some new language that's highlighted here in yellow. If using an influenza vaccine other than Fluvac or Flucelvax, administered in a medical setting under supervision of a healthcare provider who can recognize and manage severe allergic reactions. We also added 2 additional bullets. The first is if a severe allergic reaction to vaccines is that severe allergic reactions to vaccines can occur even in the absence of history of previous allergic reaction. All vaccination providers should be familiar with the office emergency plan and certified in cardiopulmonary resuscitation. And then the second bullet that was added is a previous severe allergic reaction to influenza vaccine is a contraindication to future receipt of the vaccine. We also added some additional information about LAIV4 and the use of antivirals. And the language says that LAIV4 should not be used if the person received influenza antiviral medications, and if it was oseltamivir or zanamivir, within the previous 48 hours, peramivir within the previous 5 days, or baloxavir within the previous 17 days. And this reflects the most updated influenza recommendations. In the meningococcal notes, under special situations, well, first, in all relevant sections, we added MedQuadV as a potential vaccine, abbreviated MAN ACWI-TT. Under special situations for MAN ACWI, we added some additional information about booster doses, and it reads booster dose recommendations for groups listed under special situations and in an outbreak setting, for example, in community or organizational settings and among men who have sex with men, and additional meningococcal vaccine information. See the reference there to the most recent MMWR recommendations. For the MenB booster doses, we also added the same language, referring providers to the most updated meningococcal B recommendations at the web link listed there. In the pneumococcal notes, we updated the link for routine vaccination in persons age 65 years and older. There was a new publication that we wanted to make sure that we were referencing. Under shared clinical decision-making, the order of the bullets has been changed, but the language within the bullets themselves has not. The order is now as shown here. If both PCV13 and PPSV23 are to be administered, PCV13 should be administered first. PCV13 and PPSV23 should be administered at least 1 year apart. And lastly, PCV13 and PPSV23 should not be administered during the same visit. In the tetanus, diphtheria, and pertussis notes, we updated information for wound management based on the most recent publication. And the language states that persons with 3 or more doses of tetanus toxoid-containing vaccine for clean or minor wounds administer Tdap or TD if more than 10 years since last dose of tetanus toxoid-containing vaccine. For all other wounds, administer Tdap or TD if more than 5 years since last dose of tetanus toxoid-containing vaccine. Tdap is preferred for persons who have not previously received Tdap or whose Tdap history is unknown. And if a tetanus toxoid-containing vaccine is indicated for a pregnant woman, use Tdap. In addition, for detailed information, we reference the newest publication at the link listed on the slide. In the zoster notes, we removed references to prior ZVL dosing for routine vaccination of persons 50 years and older with RZV. And then we also deleted the bullet explaining ZVL dosing for persons 60 years of age and older, since zoster vaccine, ZVL is no longer available. That's all I have. I am now open for questions. Thank you.
We're open for questions from any members. Dr. Paling.
Hi, thank you very much for a great presentation and for all the work you've done to harmonize the schedules between children and adults. I was really pleased with how that's come together. I do have one question about the pneumococcal vaccine notes. Would you mind pulling those up?
Second, there you go.
Yes. All right. So the question is, on the second bullet says that PCV13 and PPSV23 should be administered at least 1 year apart. It raises the question, do you even need the third bullet?
I see your point. I think that it's just important to emphasize that they should not be administered at the same visit. Based on some questions we get in through NIP info, which is, our vaccine question email, we still do get asked about that quite a bit, and we have seen where they're co-administered. So I think it's important to continue to emphasize that.
Okay, so it's intentionally done for emphasis.
Correct.
Perfect. Thank you very much.
You're welcome.
Dr. Atmar.
Hi, thank you. It's more a comment than a question to contrast the adult and pediatric. And again, I guess the not recommended is in all the cells, whether there's an asterisk or not on the, this is slide 40, I think, on the adult schedule, which I think for the pediatric schedule would be a problem because there are a couple of cells where there's language to identify a specific subpopulation within the group that would make putting not recommended problematic. So I don't know whether it should be not recommended written in both or with the pediatric, just have some other, whether it's the asterisks or whatever for the pregnant column to refer down to deliver it after after the pregnancy's over. So this is just, you know, you can see that where there's several cells where not recommended is written out without an asterisk, right. So it doesn't really refer to the pregnancy. So they may not be able to be completely harmonized over.
Yeah, you know, historically, the adult schedule has always had the text overlay and the child schedule has not. And I can't speak per se for the child schedule why that has not been recommended. I think it may be, as you pointed out, that some of the cells have other information or are rather small and it would be hard to read. In general, for the table by medical condition, where the adult has a lot more text overlay, and I think that's just some historical differences. We are definitely open to suggestion about how best to present this information. I think the gist from the combined immunization work group this year was with the pink is to get rid of the extra color just because it was, you know, additional confusion, and the dosing for pregnancy, it's even though on some of them it's not really a recommendation per se to delay until pregnancy. It is, you know, we don't vaccinate during pregnancy, we vaccinate after. And so the feeling was, because red now states not recommended / contraindicated, that could cover. So, I mean, that's just some of the thoughts that were behind that, but we are definitely open for suggestion.
I find the text overlay on the adult schedule as an adult physician useful. So I wouldn't propose changing that. But, and not being a pediatrician, I can't really, or an obstetrician, can't really speak to the pediatric schedule, but I think it's much more ingrained in the pediatricians, you know, what the timing of vaccination is. And so I understand and would agree with less language. And I guess the question for the pediatric schedule is how to have the asterisks stand out to refer it to the footnote, but just my thoughts.
This is Dr. Wadi. I think maybe an option can be to remove the not recommended text and just have an asterisk. I think in the 2020 schedule, this is, sorry?
Apologies.
No, go ahead. Sorry, the mic was open.
Oh, sorry. Okay. And I think I can put for the 2020 schedule, there was a cell like that just had the coloring and the asterisks. And I don't know what the ACIP members think about that.
I would find that acceptable. This is Robert Atmar.
Thank you.
Dr. Bernstein.
Yes, I actually was going to follow up on Dr. Atmar's comment. I wondered whether we actually needed the not recommended in the child and adolescent and the adult schedule, that I think just the color red with an asterisk, which would mirror the HPV recommendation as early as 9 years that occurs in the child and adolescent schedule, where there's just a cell with a color and the asterisk. We might want to change the line spacing under the red box so that the asterisk stands out a little more, and to vaccinate after pregnancy, but that may help with that. And I have one other comment not related to that.
Go ahead with your comment.
Sure. The second question was around the routine vaccination for Tdap that was proposed in the child and adolescent schedule, where it was moved up, because I noticed that we don't have that level of information in the adult schedule. And I also wonder whether the suggestion to administer Tdap regardless of the interval applies more broadly than just during pregnancy.
Any comments? Okay, next question would come from Dr. Goldman.
Hey, thank you. First, a comment. Thank you for your incredible hard work on this very complicated vaccine schedule. As a practicing internist, it is absolutely helpful to have that text overlay. One of the things I think that really truly needs to be emphasized for most practicing clinicians is they really need to read the notes section, because while the comprehensive color-coded text overlay guide is very useful for a quick glance, it doesn't really encompass the full depth of recommendations within it. So I don't know if we want to put somewhere in there, please read the notes carefully before digesting the color-coded guideline, or however it's phrased, because I know some clinicians may tend just to go right to the color code and not really fully look at all the indications in depth. So that, I think, needs to be emphasized, but otherwise tremendous work, and I think really well done.
Thank you for the comment. I pulled up the cover page for the adult schedule, and the child schedule is similar, except it has 4 steps because of the catch-up table. But if you notice, we have the how to use the schedule, and it says to look at, determine vaccine recommended by age, table 1, assess need for additional vaccinations based on medical conditions, table 2, and then review types, frequencies, etc. note. So we do emphasize that when using the schedule, you should look at all the tables and the notes, not each part separately.
So we're going to interrupt the sequence of questions here. Dr. Cohen has a question from Dr. Friedland. Please, Dr. Cohen.
Hi, can you please go to the pregnancy contraindication page and review the recombinant zoster vaccine? It's red here, but it appears to be a contraindication, and I didn't think it was.
For HPV?
No, RZV.
RZV. So it's not recommended during pregnancy. The previous language was delay until after pregnancy, and we've now changed the color to red for the simplification, with the not recommended with an asterisk, and the asterisk indicates that that you should vaccinate after pregnancy. So it's not recommended during pregnancy, even it's not contraindicated, it's just not recommended.
Great. Thank you.
Thank you very much. Next question is from Dr. Long.
Yes, this is Sarah Long. I am an infectious disease doctor in Philadelphia, professor at Drexel. And I guess I'm a member in training of ACIP, so I wasn't sure that I could speak. But Dr. Bernstein is absolutely right about the previous comment about the irrelevance of time since last TD containing vaccine for Tdap. There are situations in which an individual could have gotten TD for a wound or Tdap as part of makeup immunization. And we do want that recommendation that the timing since that does not matter. So I appreciate it. It's more important for pregnancy. Maybe you could keep the third bullet and apply it to both, or reinforce it somewhere else, but it definitely is part of the routine recommendation as well. The other comment I might have is only that, do pediatricians and adult people still Xerox this color-coded thing that then turns into black and white so that the red won't really quite have enough impact? Otherwise, I think it does make sense not to put contraindicated anywhere. And my final thing was on the hepatitis B. Early on, I saw some horizontal arrows going both ways, indicating a time leniency for the dose. And we don't do that anywhere else, and just indicate by the color and the color distribution over age groups. So I wondered why, particularly if that was put there, and if it is more confusing than helpful.
Hi, Matt. This is Patricia. Can you go to the table? I think it's table 2 in the child.
Right? It's going to take me a minute to get there.
Yeah. Table 1, sorry.
Don't seem to have control anymore. Hold on. There it goes.
Okay, this will take a while. Some of the other cells have the arrows, and in the previous schedule, the hepatitis B row had the arrows in the third dose, but not the second dose. So we just added it to the second dose so that it's similar.
Getting there.
It was, I think, maybe your first or second slide with the one more back, another back. More.
Just this one?
I don't see do I see the arrows? You know, one of the problems is, even if we make this big, are there horizontal arrows there in that red box that you've outlined?
Yeah.
But there aren't horizontal arrows any other place where you...
Dr. Long, this is Jose
Yes.
Romero, Chair. Unfortunately, you're not allowed to
Okay.
We're just gonna, because you haven't been officially named at this point, we're gonna have to ask you to abstain from comments, and we'll move on to the next person.
Thank you.
So thank you again. Dr. Hayes, I see that your hand is still up, or is that a residua from the last question?
I apologize. Yes, it is. I will take it.
Thank you very much. So I believe we've come to the end of this session. If there are any other questions or comments, seeing none. So we are scheduled then for a break at 1:30, but we, as Dr. Cohen mentioned earlier, we're going to keep on schedule. So we will re-adjourn. We'll take a break now and re-adjourn at 1:45 to begin discussions on seasonal influenza vaccines. Thank you very much.